All right, it's 6 o'clock. Welcome everybody to another edition of Butterfly's POCUS Power Hour webinar series. For those who are joining for the first time, welcome. For those of you coming back, thanks for coming back. So we host these webinars every month to support all of you in using ultrasound as for clinical decision-making at the bedside. And every month we focus on a different ultrasound application or clinical use case. Really psyched today to have a great discussion on pediatric ultrasound. And I think for all of you who care for children or for parents with kids, most kids are really healthy, but they get all sorts of sniffles and illnesses. They're really active. They fall and get traumatic injuries, and they get evaluated a lot. And that can be pretty challenging, especially for kids who aren't verbal. That includes adolescents. And we try and avoid doing invasive testing. We try and avoid blood draws. We certainly try and avoid causing harm to especially smaller kids with ionizing radiation. So clinical assessment and decision-making gets a little more challenging. And that's where point-of-care ultrasound is just so fantastic to provide a little more diagnostic insight at the bedside. And so this evening, we have two great experts in pediatric ultrasound who are going to talk about their experiences and some of the applications that they use to change how they care for kids. The session's conversational, so please add your questions to the QA sessions. If you have any insights that you want to share, we'll try and get to those all during the webinar. And without further ado, I got to tell you about a girl named Delia. So Dr. Delia Gold, she's the Director of Emergency Ultrasound for the Division of Pediatric Emergency Medicine at Nationwide Children's Hospital. And Delia, why don't you introduce yourself and talk a little bit about how you use ultrasound in your clinical practice. So thank you so much for joining.
Thank you. So I am the ultrasound director at Nationwide Children's, and I came to ultrasound probably the similar way that everyone else, a lot of people in pediatrics came to it, is I was doing my PEM fellowship back in the glory days of the teens, the 2010s. And when I did my rotations at the adult institutions, the adult EDs, I noticed they were using this crazy thing called ultrasound that I was fully aware of as a modality, did not know I was allowed to do it. And the annoying person in me was like, why can't I do that? I feel like I could do that. I was told I had good hands back in med school. I should have been a surgeon. I think I can do this. So I started practicing when I was at the adult sites, and then tried to bring it to my pediatric site and realized that there was just some political and kind of educational delays because it wasn't part of our training the way that it was in adult medicine. And then just other issues with how we use ultrasound and radiology in peds, because it's actually one of our favorite tests to do. And so we have a lot of support from radiology departments. And so a little turf war, perhaps, if you want to call it that. And just also a lot of people not knowing how to do it. So when I was a fellow, I became committed to learning how to use it. I did a fellowship so that I could do it, but then so I could teach it, so other people could not be as annoyed as me. And because I was the only one at my site doing it when I started, except for some of the adult trained doctors who were also working in my department. The focus that we had on what we wanted people to learn how to do is I wanted to teach in my curriculum people, the fellows, ultrasounds that would be very impactful for patient care, ubiquitously able to be used, and that they'd be highly proficient. And so able to use kind of core scans, classic kind of ultrasound scans, whenever they needed them, so that they would never feel, they would only be better physicians because they had them. So generally, I focus on kind of what's accepted as the pediatric curriculum for both really for fellows, but also attendings who have an even briefer list, because, I don't think there's a saying about old dogs and new tricks, but I don't know, I'm not sure. I would say they are not as available to learn new skills. And so the ones who are interested, we kind of expand the curriculum so it matches what a full fellowship would focus on. But there's still core scans like cardiac, fast, bladder, vascular, that we would, and heart, obviously, that we would have them do. And so we generally focus on that when we get people who are super into it. Like Russ Horowitz, my podcast colleague, we'll do expanded indications like ocular and DVT, all that stuff. But really, the goal at my site had always been that I wanted people to be able to use it if they needed it, especially in a sick patient, and that they felt confident with their results. So that's kind of, we generally focused on that.
Yeah, that sounds great. Certainly, just being able to use it when it's needed is such an advantage to have that reflexive skill set. We also have Amanda Toney, who's on, and Amanda, she's the Pediatric Emergency Ultrasound Development Director and the Director of Pediatric Emergency Ultrasound at Denver Health Medical Center. And under duressful circumstances, Amanda, thanks for joining. And again, if you want to talk a little bit about your background and what you do in your day-to-day work with ultrasound and which applications seem to be helpful. How's your husband, by the way? Well, so for everyone listening, Amanda is in the peri-op space and was trying to log in with a surgery happening. So Amanda, if you can hop on later, or when you get sound, we'll come back. I'll reach out to Russ. Hi, Russ, podcast colleague from Delia. Russ is a good friend, and he is the Director of Emergency and Critical Ultrasound at Lurie Children's Hospital at Feinberg School of Medicine. And Russ, we were talking about different applications and it's kind of bread and butter stuff. And in your world, you see a lot of sick kids, so your bread and butter has been more heart and lungs. So, tell us a little about your background and what you do.
Thanks so much, Peter. Delia, always a pleasure to see you and to see everybody out there. So I'm a little bit sort of stuck because I work at a tertiary care children's hospital. We have a ton of resources, so I take care of some really complex patients. But I also have patients who are healthy kids with no pre-existing problems. And I think the thing that we often describe in medicine in general, and whatever specialty we go into, is the things that sort of reminded us of the stories that started us down a particular road. And I have had, particularly when I first started doing ultrasound over a decade ago, it was a very simple case of what I thought was going to be a simple cellulitis, and also a teenager who was kind of tired, who my guess was he had mono or a little bit of anemia. And those two things became life-altering problems that would have been extraordinarily difficult for me to find out without ultrasound. And those are the ones that inspire me and then also keep me up at night when I start reflecting on some of the things that I could have very much missed, and that in the absence of ultrasound, that we won't necessarily get to until things get worse or until there's an outcome. And then sometimes someone says, how could you have ever identified that was going to be the source of the problem? It's so unusual or so rare, or why did you even think to look for X? And I think the beauty about ultrasound, and particularly in the littles, is that the imaging is so beautiful. Their pictures are so wonderful that we can get usually really great pictures. And I don't usually go into ultrasound thinking, here's my differential diagnosis, I'm looking for these kinds of things. I treat it like I'm examining my patients. And in that case, when I go to examine someone, I don't look in their ear thinking, am I looking for otitis, or am I looking for an effusion, or am I looking for something unusual like a cholesteatoma? I look in their ear and then I interpret what it is that I see. And in point of care ultrasound, I examine the patient using ultrasound, and then I interpret the images that I see. Sometimes, the vast majority of the time, it turns out that the answer is what I thought it was going to be. But every once in a while, there's something unusual. And then you look like a genius because someone said, I would never have thought about a PE in a healthy teenager. How did you know to look for that? Or why did you think that? And my response is always, if I'm looking at someone, then I interpret the images, and then ultrasound shows you what's true, not only what you think would have been there.
Yeah, I remember one of my most memorable first cases in pediatrics was diagnosing a 13-year-old who had a bag full of gallstones and had gone through 2 years of GI specialists of why he had this chronic abdominal pain, because you never would have thought to look at his gallbladder, and holy heck, there was a bag of rocks. Amanda, welcome.
Thank you so much for having me.
How's your husband doing?
He's doing well. He's in the operating room getting his Achilles repaired right now after a pickleball accident.
There you go. So again, everyone, please welcome Amanda, who's joining us from the perioperative area. And again, Pediatric Emergency Ultrasound Fellowship Director and Director of Pediatric Emergency Ultrasound at Denver Health Medical Center. And so, when we met, you were talking about how you see a lot of healthy kids that have these applications that you use pretty commonly, that in that spectrum of patients seem to really help a lot in terms of your patient care. So I wonder if you want to introduce yourself and dive in a little bit to what you do.
Sure. Thank you very much. So yes, I work at more of an intercity safety net hospital, and we do have a separate PTD as well as a pretty large adult ED. And in the PTD, we generally see your healthier kids, and some of the quaternary pediatric hospitals would. And I think the highest use, looking at our butterfly cloud in terms of what our pediatricians and our PEM providers, what applications they use on our kids, and it's most likely to be soft tissue and also assessment for intrauterine pregnancy. So we do treat patients who are 19 and younger who are pregnant. So a lot of our assessments are using those two applications, and we can really expedite care, decide whether a procedure is necessary in terms of abscess or no abscess, or foreign body or no foreign body, and also assess for intrauterine pregnancy in a fair amount of the time, expedite that visit and not have to send our patients for intrauterine pregnancy. I think that we're kind of really excited of getting more into at Denver Health would be nerve blocks. We were taught fascial iliaca blocks blindly initially without ultrasound, and now we're doing them more readily with ultrasound for femur fractures, and we get a fair amount of femur fractures from the mountains in the wintertime from snowboarding or skiing.
Oh, yeah.
So that's something that we're kind of trying to. That's sort of our initial nerve block is fascial iliaca, and trying to branch out from there as well.
And are you doing those in all age groups, in terms of your pediatric patient population?
Yes, we're doing those in all age groups. And we tend to use, in terms of Arun Negdev just gave a great nerve block lecture at the P2 Network conference. And he sort of stresses like the multimodal pain method, in which you're, potentially treating kids even down to 3 years of age with, pain dose ketamine, and also using child life and your J-tips in addition to your nerve blocks. So once again, using multiple methods to try to reduce pain and anxiety for kids. And then therefore, most of the time being able to do nerve blocks, even in children, I would say down to 3 and 4. And then we treat up to 19 years of age in our institution as well.
Fantastic. Delia, you've been doing some research with EFAST, and there's been a bit of controversy in terms of doing EFAST in pediatric patients. I wonder if you want us to go into that a bit. It's pretty fascinating.
Man, that's a big thing you're dropping in my lap. No, I'm just kidding. It doesn't need to be controversial, and I definitely want to be thoughtful to the authors who are of the paper that kind of the JAMA PEDS paper that people felt was controversial about FAST and using pediatric FAST, because they are also the authors, the PIs and senior authors for the new PCAR and FAST study that's coming out that we're working on right now, and which my hospital is one of the sites. And I think, I don't know. I think that people who all use FAST scan. So the controversy, for those who don't know it, if you care, I want to go into it a little deep, is that, because who knows who's listening, is the FAST scan is kind of the baseline ultrasound that we use in POCUS. Like, it's what started everything. If you read the textbooks and you talk about ATLS and trauma and how can we make like bedside interventions with ultrasound, it's the FAST scan. Well, that was, quite a while ago. And now with kind of improving imaging and techniques and various things like that, the idea and us in PEDS kind of having more and more evidence that you don't need to take patients to the operating room, even if they have like a solid organ injury and they're bleeding significantly, because kids often can bounce and do quite well with injuries in a way that adults cannot. What is the point of doing a FAST if you aren't rushing them to an operating room? Well, I think that's a good question and everyone understands, but then the real answer is that we do a lot of things. Like you can't just say, oh, you're looking pretty stable and you haven't, you look like something's wrong, but we know we don't take you to the OR, so we're just going to stop. So we do need to have like more definitive diagnosis and kind of management to make sure we're not missing things. However, that often is a CT scan, which has a lot of ionizing radiation. And we have this kind of test in our pocket, the fast scan, that people have like looked at for years about initially how can it get you to the OR faster? Can you just go straight to the OR and avoid imaging? But in a world where, respectfully, a lot of surgeons are not going to be okay without definitive imaging, but additionally, they might not need OR anyway. It's kind of how do we use this test? And so the controversial paper was it was controversial more in how it was said, but not actually what they said or at all how it was done. But it was a single site study and they looked at using fast scan to actually reduce CT rate, because that's really kind of a more impactful measure if you're not taking kids to the operating room, right? And so, at that one site, there wasn't actually great impact of using a fast scan. But as Amanda was just talking about her site and how she sees up to 19, which I see way over 19, but we do not look for babies. If babies are on the table, those babies can waddle on down. Like, unless they're emergently not well, that is not something that we are routinely looking for as part of our care. But we also aren't, it sounds like at her site, they're probably getting HCG levels and they're actually like managing it. For us, we don't have that infrastructure. So scans are specific to the site, right? So at this one site for the paper, where they're doing ultrasound, it's a lot of it has to do with what kind of patients are coming through, what are the surgeons comfortable with, what is the end outcome. So really the paper was almost more measuring people's comfort with using fast scan as opposed to like the scan itself, which the authors actually very readily knew. And I believe, to shout them out, even were aware that there was going to be a reaction, but said, well, data is data, and we publish what we found. And then, but it just gave more fodder for like the next stage of the study, which is a multi-center prospective study to kind of get to the bottom of some of the questions that first study brought about, like how can this test be useful? Can it reduce CT? Are there bad outcomes if you use it? And I think that I think we all agree anecdotally we can all come up with at least, a handful of cases where it mattered, but I'm optimistically hoping we'll also find it in the data. So that is that's why I was, we do bread and butter, but the bread and butter is coming back around, guys. but nerve blocks are cool too. And I want to learn, I want to get better at those. So that I know is sexier, but I'm like going backwards thinking about the fast scan.
Well, yeah, and one of the things with bread and butter is also the confidence in negative with bread and butter, right?
Mm-hmm.
So how do you do an ultrasound and be confident that the decision you make? And negatives are easier in the sense that if it's negative by rights, you can stop, but that takes confidence in interpreting negative. And Amanda, I think we were talking about one of the how does this translate really into the community, or the idea about even cathing kids, right? So a simple question is, when you take a catheter and check for a UTI, is the bladder full or not? And a simple way to reduce invasive procedures. I think you do that in your shop, and it seems like that's something that translates pretty easily into the community world of something that's especially with a auto bladder scanner, a way to just say yes or no, is there fluid to put a catheter in or not?
Yes, we're just finishing up a study with our nurses. We're educating the nurses to do the bladder ultrasound using the auto bladder volume tool on the Butterfly. And our final data collection week is this week. So I've been dragging my children in as the models to see how our nurses are performing after 4 months of education. And we're also tracking them to see if we can show an improvement in the first bladder cath success, because we will basically, the nurses assess for a minimum bladder volume before cathing the kid, because we've all had those kids, and especially the nurses have been on the front lines with having kids in which they've attempted to cath and they come out and they said there's no urine, right? And it's pretty sensitive procedure, right? And have to go ahead and repeat it again and trying to convince the parent to actually get a second cath. We are attempting to reduce that first cath failure rate. So we're collecting data. Other groups have shown that they've been able to do this successfully and reduce or improve the first cath success rate from the mid 60s to the mid 90s. So the one thing that we're trying to use is a little different, is that the nurses are using this auto bladder volume tool. But yes, we're hoping to reduce the stress on our patients, on our parents, and also on our patients too.
And are you?
I think
And
it's
nurses.
stressful. Well, I would say and us, because I get super
Right.
stressed when I'm sitting there crossing my fingers waiting for a urine, and then they just leak it on out. So I think it's great that you're doing that, because it stresses everybody out for different reasons.
Right.
I
And the
just
nurses
had
too.
it the other day, so I just popped into my head how stressful it was for me, because it's all about me. I'm just kidding. Not.
No, nothing. But I also get families, this maybe is going to tie in a little bit what we're talking about. A lot of the stuff that I do is focused on me and what my care is like. But I'm starting to get more people who are more involved and more empowered to have a discussion about why it is that I'm doing what I'm doing, and is this the right thing? And because everyone has easy access to information. And I think having a really good partner makes it in some ways easier, because everyone's sort of working for the common goal. And I've had parents say, well, how do you know that there's urine there? And up until a couple of years ago, it just was like chirp, chirp, chirp in the room where no one would say anything. And we're like, well, we don't really need that much. But now you can just look and see. And so you look, and if the bladder is empty, then you're like, oh, we just need to wait a little bit. Or it helps me sort of understand, like, maybe the child is drier than I had thought, or maybe there's other circumstances. And in our setting, it's pretty easy because we have a lot of nurses and a lot of medics who do that, and a lot of resources. But I can only begin to imagine what goes on in a pediatric office when they're seeing a zillion kids at one time, or people might not be that comfortable with catheterizing a little baby. And now it means that they got to do it again. Mm-hmm. And then maybe they ask the doctor to come in and do it, who's already running around seeing a zillion people. So this just sort of streamlines the care and really lets us sort of have a better kind of discussion with families and say, oh, look, see, the bladder's pretty big, all that black stuff, that's all urine, there's a good amount, or there's not really that much, so we should really wait a while. And maybe your kid needs some IV fluids, or why don't we feed her, and then we can reassess in 20, 30 minutes and see what we got.
Yeah, I feel like you're also bringing up the difference in peds, which is intrinsic to the medicine, but also specific with POCUS, which is, since it's a, particularly if you're using a handheld or a machine that's on cart, in peds, the parents are a huge part of the care. And yeah. I guess maybe it's different where I am. There was never crickets where I was. I had a lot of, what are you doing? Like, what's that? Is that the heart? I'm like, oh my God, no, that's not the heart. It's a bladder. Like, good job. So, involving the families and even the patients as they get older, like we always talk about how hard it is on kids sometimes if it's like they're upset and they're in pain, but also if they're not upset, if they're not in pain, if they're not cold, they love the ultrasound. Like they're staring at it. They're watching what you're doing. You kind of have like a clinical alliance that's even beyond what you would do by practicing medicine. And I feel like, and also just like, since I do a lot of education, like the interactions with families when you're doing educational ultrasound, like it's a totally different site than when you're actually their physician. Even as someone who does a ton of ultrasound, it's like, I feel like I can focus on teaching them or answering their questions or making them comfortable and making them feel good about the plan, kind of the team thing, where I'm like, I'm not your doctor, but like, this is what they're looking for. And we have a whole cadre of people who are trying to get the best care for your child. And I know that's like the tenet of pediatrics, but I do think POCUS intrinsically kind of speaks to that more than, some other things. Also, it's helpful that it doesn't hurt.
Yeah.
Just a little.
That's cool. Just a little cool. I really like lung as an application. I think that it sort of bridges the gap from primary care to critical care, emergency medicine. But I was initially faced with people saying things like, well, you can't really do that, or we have an x-ray. or the family really wants the x-ray. And
Mhm.
I really fly in the face of that, because the universal thing that families say when you put an ultrasound or you even talk about it is they talk to their kid and they said, oh, this is what the doctors use to see you in my tummy. And so the docs who say the parents really want an x-ray, I think is our impression of what people want, and probably fear of using this tool. Because when you ask families, is an ultrasound a good tool? They're gonna be like, oh my gosh, yeah, it was able to see the sex of the fetus. And we were able to see the heart even when you were really little. And so my question to people is often, if families sort of feel that ultrasound is this powerful, amazing tool that was able to tell the sex of the fetus and make sure your heart was healthy, what makes us think that they're going to disbelieve an ultrasound for pneumonia? And horizontal lines are normal, vertical lines are abnormal. Boy, that's pretty easy.
I think those people are projecting. I think they don't believe in ultrasound. And they're using them as the parental shields to their own concerns, which understood, but it's just they don't know all that we know.
Yeah, you know more.
We do know more about lung ultrasound. I have to shout out, I'm not going to mention their name because that would be a HIPAA violation, but I had the wonderful opportunity to do a lung ultrasound on a pretty sick child, like in the middle of the night, and I was teaching, and I noticed that the father was listening very intently and was like, why are you doing an ultrasound to look for pneumonia? And it was actually one of our radiologists. And it was funny because I actually think it calmed him down because it distracted him. A radiologist with imaging, man, he started like looking, and then we talked about his child, and then we bonded because he kind of needled me, and I was like, oh, are we doing this? Okay, but it'll trust me, this is right. And now we always remember that. So I think it's just that lung is, it's a later one for some people, but with all the stuff that actually comes out of, Amanda's wonderful home institution and home state with the bronchiolitis guidelines and, rest is best and all of that stuff. We talk about chest x-ray, pneumonia is one thing, sickle cell pain, chest crisis, that's another thing. But like bronchiolitis, that I bet, Russ, that you love calming people down who are worked up, who have bronchiolitis. I feel like that might be your jam. Is that one of your jams? Because for anyone who's not peds, bronchiolitis obviously is the worst. And it is, you need a crystal ball, you need like a big honey blanket to calm people down, you need something to make them eat and stop crying because it's always worse at night. And it looks a little like the asthma. Ooh, it's the worst. And you're not supposed to get chest x-rays. That's a whole nother webinar. But ultrasound, I see Amanda nodding, that would help for some of the parental proof that we need, perhaps. Or even proof to other people, right? Like resident or the fellow or whoever is telling me I need to do a chest x-ray. So it's your jam, isn't it?
Yes. And I think
go ahead, Amanda.
Well, I think you guys bring up another really good point about lung ultrasound too, is that we have a family medicine POCUS fellow now, and we're sort of trying to reorient our approach to POCUS of what applications do we need in the clinic, right? She's not so interested in learning EFAST, et cetera. So she brings up as lung ultrasound as being one of those really high yield applications for clinic, potentially because they don't have x-ray right next door, right? So clinics or even, rural practitioners too, I think it's a great tool for lung ultrasound to really rule in, rule out larger consolidations and plus or minus effusions, suspected empyemas too. So I think that's a really important utility of ultrasound for not only in the hospital, but also in the clinical setting.
Yeah, it's the idea of, we know we're not supposed to do chest x-rays, but most of the kids come in with fever, and it strikes me a little bit as if someone says something like, well, I think I hear differential breath sounds, or maybe there could be pneumonia. The parents were talking about fever. It's kind of like saying, maybe you're pregnant. Like, you got to take a look then at that point. So and a lot of the ways that ultrasound sort of got presented to me at first was that we're going to talk about rule in or rule out. And like pneumonia, that's harder because it looks a little funny and the organs are sort of hard to distinguish. But what I think I've seen in the last couple of years is that as we're getting more people, and peds is sort of behind, but more people who learned a little bit about ultrasound in med school, and the test characteristics are really, really good for lung ultrasound for pneumonia, particularly in pediatrics. People believe that as true, thankfully. And now trainees accept information from attendings. I mean, they're usually asking very good questions, but they know some test characteristics. So the lung ultrasound study that was negative is a great way for people to really accept the fact that we don't need that x-ray anymore for the kids who have asthma, for the kids who have bronchiolitis. And I accept the fact that there are going to be people who, once a patient's admitted, if they're remaining there for a while or they're getting sicker, then we investigate further. And that makes a lot of sense to me. Thankfully, I just work in the emergency department and I don't work upstairs, which is probably good for both me and the patients. But when circumstances change, we do more. And I get that. But the good part is now we have a tool that makes families comfortable, practitioners comfortable, and can validate in some ways what our concerns are and sort of say they don't have pneumonia, or now that they do, then we need to do more for them. But it validates the fact that auscultation means Zippo, because the lung sounds and a screaming little person, boy, those are real hard. And now we know for sure. When people are like, how do you know there's no pneumonia? I looked at the ultrasound. They're like, oh yeah. And they do literally write that down and they check the little box. They color in the little square that there's no pneumonia. And now, as we're getting some of those older attendings who've now gone on and retired, we're getting new younger people who are hospitalists. Those are the ones who have learned ultrasound in med school and hopefully a little bit in residency. Now they're accepting that as truth as well. And everyone's now on the same page.
And there's actually two sides of the coin as well in terms of this and using x-rays, right? Because I think we talked about how what you get trained to do with kids is really do nothing, right? So you're not supposed to order x-rays, because if you order an x-ray, you're doing ionizing radiation. So a lot of times we make decisions based on a gut instinct, which thankfully, because kids aren't that sick, is often correct. But it's because we didn't want to use another technology or tool to just ask the question more succinctly. And so as you're talking about, horizontal lines are easy to see, vertical lines are easy to see. So you have the child and put the probe on versus even the stethoscope, and the parents could see the horizontal lines. That's so much more reassuring than saying, I think. And one of the things that I speak to, if this is something that you've seen as well, for the chronic lung kids, like the CF kids, it's been the opposite. Parents come in and they're just demoralized that every time they bring their child in to see us, they get another picture. And they're just in their mind calculating how many chest radiographs have they had in their lifetime, and they already have one disease and they're terrified about cancer as a second disease. And the experience that I've had, certainly when I've taken care of a CF kid, where instead of sending them down to the radiology, put a probe in their chest and show mom or dad and the child, who's often at that point in time a little bit older, that the lungs look clean. There's those horizontal lines, just as transformative. So I don't know if you've had the experience with the chronic lung kids as well in your practices.
I would say that for CF, I think when they, probably due to the excellent care that is provided by my local practitioners, they come in and they would not have a clean ultrasound. That's kind of how that's why they're there. They try to keep them out for as long as possible. But I do think it speaks to the idea of even some of the other utility of point of care that isn't maybe what I use it in the ED as much, but like a lot of these other pediatric indications like IBD, for example, where you have a chronic finding or chronic risk of something that's abnormal, that you can do at bedside over and over again. And like, even if it wasn't, quote, normal to start, it might have been their normal. And now this change that I'm seeing 3 visits down is this is not their normal, this is different. So I think the kind of the way that you can just repeat ultrasound and it's the same person, like even I'll remember, where my hand was when I saw that thing that I have to go back to. And so I imagine for anyone with chronic illness, we're starting to see that there's more utility on serial exams, which I just don't think I see necessarily in the ED, but even up to the ICU, like IVC and various things, like we can start with the IVC and the ED, and then they can track it up in the ED, up in the ICU, as well as like B lines and various things. So it's still kind of the continuum of care that I think that the modality is specifically useful for. But yeah, they love anytime you don't have to do something uncomfortable or radiate the child, I'm sure is always it's a winning day.
Like the repeated PICU x-rays daily in the morning that used to occur when we rotated back in the day. So now we can really use ultrasound to really monitor that effusion, you know, that consolidation, much more information compared to a single view chest x-ray for sure.
Yeah, and in our institution, I think they, you know, they worry about it for the PICU, but I know the NICU in particular, like a lot of the kids who are intubated for quite a long time and they're very stable and they're just kind of growing, doing like ET checks to make sure that they're not like moved too much. We have talked about doing that and had some QI, because in one of our units, they sit for such a long time that they're like dancing and moving all around, but it's not like a tube in some ways. And so they had looked at, can we kind of try to unplanned extubations in the high riding tubes and the moving bigger babies, like the chronic ones, is something that they've looked at, I know, about feasibility. Instead of rolling.
No, I like the idea.
X-rays.
I like the idea of that, because sometimes I feel like I'm practicing just in like this own little island. You know, I don't see a lot of attendings. I talk to people on the phone sometimes, but I don't get to see their face. And it used to be that my studies were sort of done in isolation and no one can see them, or it was just that ER thing. But as we're talking about it, it sort of reminds me that we're part of this continuum of care, right? So my discussion with someone saying the lungs look great now, but in a couple of days, if something's different, then of course further investigation is necessary. Or the person is really fluid down now, we're going to do a little bit more, and over time they're going to see that IVC get a little bit fuller. Or I think everyone has that one standout case, or half a dozen, depending upon how long you practice, where the kid really was asthma or bronchiolitis, but was breathing a little fast. So I end up putting the probe on those kids' chest, just even though I think that it's going to be asthma or bronchiolitis. And about once a year for the last like 20 years, sometimes more, we end up having a kid, usually in the middle of the winter, usually someone who's had asthma before, who ends up having myocarditis. And those are the ones that like keep me up at night, because before ultrasound, those kids were getting sent home. And now it's this is the bad function. We call our cardiac intensive care unit, and thankfully we have those specialty resources. But now I can say not just somebody has a bad heart, but I can say someone's ejection fraction is 12% because their fractional shortening is 6. And that gets all the resources mobilized. Everyone knows what that means. And instead of that kid getting the complete echo downstairs in the emergency department, which is going to take 30 or 45 minutes and really tap the resources of people, that person gets moved to their specialty care service. Or if you're working in a place that doesn't have that, transferred over to the cardiac heart center. And now we can focus on what we're going to do and what we do the best, which isn't maximize someone's cardiac output, because that's really the area for the specialist, but end up taking care of everybody else and sort of offload some of the cognitive load. So I can't tell you the number of times where we call them and we say, this is it. They look at our image and go, oh, we'll do the complete go upstairs. Let's get the kid moved up. Because they also know that that's not our area of specialization. And those are the ones that really stick out in my mind, because I don't know that I'm going to be that good to feel a toddler's belly and say that the liver is a little bit big. And I don't know that I'm going to be able to distinguish between asthma sounds, bronchiolitis sounds, and wet lung sounds in a screaming 4-year-old. And all the people who say that they caught it after the bolus. Like I give them big kudos because I don't think I'm going to get there. And the idea of practicing and taking care of all those kids, particularly in the middle of the winter, without ultrasound makes me really nervous because I know that there's one of them hiding in there like every day. And I don't know who they are. And I don't want to x-ray them all, and I don't want to EKG them all, and I don't want to do all those labs on all of them just to be sure, because at some point I'm going to say they're all going to be normal, except for that one who's not. And ultrasound just tells you. And then you look like a genius. And all you're doing is...
You look like a genius anyway. Look at
you're
you.
so nice to me. Oh, come on.
Look at you.
Yeah.
Look how smart you look.
Well,
But
it looks like you're smart, but it's because you're like, that's what I'm doing. I'm doing the right stuff. And everyone's like, wow, you didn't do an EKG, you didn't do a chest x-ray, you didn't do all those labs. And my response is, I just did the ultrasound. I saw that their heart was normal. They don't have B lines, and they have a couple, they don't have B lines significant enough to be pulmonary edema. It's just a typical pattern that we would see in virus or in bronchiolitis or in asthma. So
Sort of that eureka moment, right? When everybody's kind of scratching in their head. Why is that kid so tachycardic? He's not febrile. He's not in pain. You know, what's the etiology? And we're like, I did EKG. It's just sinus tach. And you're like, well, did you look at the heart yet? And they're like, no, let's go look at the heart. You know, and most of the hearts I look at are normal, but every once in a while I can think back to a kid, a teenager with weight loss and unexplained tachycardia with a slew of normal labs. And he's got a large pericardial effusion and a mediastinal mass on ultrasound. You know, it's rare, but evaluating the exact organ you're concerned with via ultrasound can definitely be helpful.
Yeah. And I guess it reinforces the idea that the vast majority, kind of like Peter was saying, the vast majority of tests that we do in pediatrics are normal, but that never negates people's perspective of just checking lights to be sure in the kid who's dry, or just doing the x-ray when I hear an extra sound. But I often hear people say, oh, like all the ultrasounds are normal. Like, why do you keep doing those stuff? In pediatrics, they're always normal, like it's okay. And in pediatrics, like you could examine children with your eyes closed and you're going to be right most of the time. Right? Until you practice long enough or until you're wrong.
see, I don't even touch them. I just look.
Well, you use the ultrasound.
You're one of those doctors. Okay.
Yeah.
Well, she's been doing it for a long time.
I'm just kidding. I was just laughing that you were saying that you can, you know, you'll be right without even having to do anything.
Goodbye, Amanda. Realize your husband.
Thank you so much for making it. Bye-bye.
Oh yeah, I'm sorry. I hope he does okay.
Thank you, guys.
So one thing in the background here, which is really interesting, is that when you describe that you're having these aha moments and most kids are normal, it's really because you've, in your practice style, have learned or evolved that you pick up the probe and just take a look. And always that adage that there's, you know, again, with ionizing radiation or invasive procedure, there's a cost to looking. There's a cost to doing a catheter in a kid when they have a dry bladder, but there's not a huge cost in putting a probe on somebody. And then so one of the challenges that interested in your thoughts on is how does that appreciate that sense of achievement in terms of what that probe does for clinical practice? How does that expand into a group or users who have not adopted as readily? And one of the common themes, if you're in a hospital setting, right, there's always the ability to order other testing. And so what's the difference between ordering or testing yourself, Russ, versus waiting that half an hour or 2 hours or 3 hours for the other tests to happen? And then, Delia, as you talked about the interaction with patients and parents, you don't, what a difference when you walk into a room and say, hi, mom and dad, I ordered that ultrasound of your belly for intussusception. It's normal, but it's been 4 hours later. They've been controlling the kid. They don't see the kid versus me having the probe in the belly. Right. So I think about the challenge of how do you demonstrate that, or how do you get people to really appreciate the sweet spot of that skill set in terms of getting adoption? I wonder what your thoughts are about that.
So I think this is actually, I think this is a really good question, because I know Russ pretty well, and I'd say we aren't very different, but we're different in that I'm different in that I think that buy-in in some ways has to be earned. And that in the world of all these things that, I mean, AI, ChatGPT, portable MRI, like all these crazy things that are coming through. I want to make sure that whatever I'm kind of selling or trying to get people to use is impactful, and I play to the larger group. So I totally know what Russ is talking about. Like, I do have the cases that I whip out when I really need to shut people up. But in general, I try to, I had a folder, like when I was starting my program and having to like do some of the political things a long time ago, of like cases that mattered. And it was different categories. It's cases that mattered depending on what the person I was talking to needed to hear. If it's someone who just needs to understand it's a useful modality, because there's a ton of people who still don't know, like we're talking about lung ultrasound. I have to remember there's a ton of people who still don't even know about it, do it, care about it. I might tailor what I teach or my case to them in a different way than I would have like a very nuanced conversation with somebody about the utility of lung ultrasound and acute chest pain and sickle cell pain crisis, and what do I do with it? And so, or if it's like the C-suite of the hospital trying to make an argument for a like a middleware program, or a way to like keep track of everything, or to get cardiology on board. And so I think I know that it is, I do, he talked about his island and being on a little bit of an island. I'm okay with like a little bit of an island, because really I know the island's not that small. And I don't want people to be turned off by what I generally think is like lack of understanding and lack of familiarity and lack of comfort. And I don't want it to feel like that to them. So I kind of try to meet them where they are and get the buy-in that way. And recognize that, Russ will look at every heart, but Russ is really good at hearts. So like Russ can feel good looking at a heart. Not everyone else feels that good looking at a heart. And I've seen people who felt a little too good looking, who mistaken like, thought something was bradycardia when really it was like horrible heart function in a teenager. And they're just so used to looking at kids that they were like, no, that's fine. They have a slow heart rate. I'm like, it's not squeezing. It's just shaking. It's not squeezing. And so I know that as a real thing. And so I kind of sit a little more on the trying to meet them where they are, and knowing that they're not going to feel, I know that getting more looks will make them get there, but I also know there's just limitations with the way the world is, and education, and, COVID, and wiping everything down. It's just like the world is a crazy place. So I'm just trying to meet them where they are, to get them on board with how good ultrasound can be, especially if it's just something that you can do and know when to use it.
I think we're pretty similar.
We are pretty similar. We're close. I didn't say we were like totally far apart. I just know that Russ was my first teacher, by the way. I feel like this hasn't come out. I literally went to an ultrasound course. How many years ago was it? A bajillion. And Russ was my teacher. And that is the first time I met him. And he was just like, scan everything. And I was at a hospital where I was going to get nailed if I did that. And I was like, this guy's got it so easy. He could just scan everything. And then I realized, no, he was just a couple years ahead.
Yeah.
In intelligence and
just age. So here's my thought. Yes, I very much keep those stories in my pocket, because they both inspire me and highlight utility, but I recognize that they're rare. And I also recognize that the way that I practice medicine, using ultrasound and without in other circumstances, is different than the way the people that I work with practice medicine. So I include ultrasound in some ways in that same umbrella. As an example, there's one attending, every kid who has persistent vomiting and fails Zofran gets a line, a bolus, and they check their electrolytes, including a CMP. That's just the way she works. It's the way her mind works. In my perspective, if I might give you like an extra little try, we'll do it a little slower. And if I give someone a line, I don't give them a bolus. I give them a bolus, but I don't check their lights all the time. And that's just because we're different in the way we think about things. Another partner, she asks like a lot of questions about the family, and sign out is very extensive. It's the way her mind works. It's just not the way my mind works. So I recognize that we work in different ways and we use different bits of information. And if I'm the only person who's responsible for that patient, then I can do basically like how I would practice entirely. But when I start to involve other people, whether it's that I'm signing out to that person because I'm going to get more information because I know she's going to be ultimately responsible, or I'm going to be speaking to a cardiologist, or I'm going to be speaking to a surgeon or a critical care person, then I need the information that's going to paint the story to make them more comfortable so we all can work together. So if I have a kid who's got pneumonia, but is non-hypoxic and has no distress, then I can just do an ultrasound, no x-ray, and I send the kid home. If I have someone who has appendicitis that I diagnose, I understand that the surgeons are going to use the ultrasound information and a lot of other detail because they're the ones with the knife. So for them, a complete radiology study that evaluates a lot of other stuff that I don't know is essential to their care. But if I can identify that someone has appendicitis, even though we're going to order a study because the surgeons use different kinds of information, I can start the person on antibiotics. I can tell the family, your kid has appendicitis. You can take the other child home, and this is basically the time frame. You're going to not have to miss work for another extra night if you're going to sit here waiting for another study. And or you can like call your job and say you're going to miss work tomorrow because this is the sequence of events. And then I can book that kid's bed. And I will tell the surgery resident that I did a point of care study and the kid has appendicitis. And then as they're about to say, well, what about radiology study? I can say, we're going to get the radiology study. And that means that I can meet them where they are, kind of like what you're describing. It also means that I don't have to put a cognitive weight on that patient anymore because I know what the source of her problem is. And I can apply my cognitive skill set to the other 10, 15, 20 patients that I might be caring for. And that means that we've offloaded all that stuff and can really prioritize the care instead of doing like an ultrasound of the kidneys and have radiology do the ultrasound for the appendix and maybe do an x-ray to make sure the kid doesn't have a lower lobe pneumonia and doing a lipase to make sure the kid doesn't have pancreatitis. It just streamlines what I do. So maybe it's in time that like, I'm sorry, Peter, one more thing, just to sum it up and make sure that Delia and I are on the same page is that, yes, I have those thoughts in my mind, and I'm also coming to the people where they live so that we all can work together and understand kind of the limits of what we can do.
I think we're on the same page.
Well, what I was going to say is that this is really medical practice where you have to check your ego at the door, and we all practice differently. One of the beautiful things about ultrasound is that it's another tool in the toolbox. And so some people, there's a different spectrum of where people are using ultrasound, but I think those of us who use it understand that if I'm practicing at the bedside, I get to use it and make decisions. And there's pretty preponderance of evidence and data that I'll probably be faster oftentimes at getting a certain diagnosis. When I involve somebody else in that patient's care, it's of course differential to what their practice and what their challenges are. But that ability, just as you described, Russ, to have that cognitive offloading of what am I dealing with, and have that with the parents and the child is just really, really astounding.
Yeah.
So we are coming up on time. So I was hoping that each of you might take a few minutes to, first of all, maybe talk about one brief case that was transformative for you. And as you talked about, they're rare, but they stick in your brain. And also, if you had something you might say to our listeners about ultrasound and maybe their ultrasound journey, that might be a nice pearl for them to take home. So Delia, I'll start with you. And
good. I'm going to go first, Russ, and I have heart cases, so you better start thinking of something else. So I had two heart ones that popped into my head. One was, it popped in my head when Russ was talking about winter, and just, we had a kid, it was my fellow at the time who now is an ultrasound director, actually, out with near Amanda in Denver area. And the kid had what looked like bronchiolitis, tachypnic, runny nose, congestion, etc., really having trouble breathing. He was a very interested ultrasound person, so he just took a look. He didn't actually have any reason. In retrospect, there was probably some interesting things about how they were acting and that they weren't kind of looking like normal bronchiolitis, but it was subtle. And he looked and he just knew the heart didn't look right. That's what he told me. He was like, it just didn't look right. So it didn't matter that he couldn't say what it was or give any real detail. He just knew it wasn't right. And so they did, the kid was pretty sick. They did all their stuff, but they gave fluid and then they got sicker. And so he was like, heart's not right. Got sicker with fluid. I don't know. And I love that he did this. Because we always talk about, oh, knowing, Russ talked about fractional shortening and all that stuff. We're ER, man. We can kind of just drop things if we want to. And he called the cardiology team and said, I don't know. It doesn't look right. Their liver is down after a fluid bolus. I'm happy for you to come look at these pictures. The chest x-ray also looks weird. I think this is something in the heart. I can't tell you what, but I'm worried about his heart. Can you come do an echo, like a quick echo? They got slightly annoyed, but honestly, not really, because there was enough that they were clued into. And it was actually a kid that had cor triatatum, which is 3 atria. And the third, like the extra atria flap was basically obstructing their outflow track. So they were getting heart failure. So I don't think most of us know what that is, but my fellow, he said, but it ain't right. And so it worked. And he did just look. And he didn't need to know everything. He was just like a PEM fellow at that time, not a POCUS fellow. So that was a good case that I always will like bring out for people. And then for my, go ahead.
I was going to say, no. So what would you say to that's an awesome case. What would you say to the listeners about their POCUS journey?
Well, I would say to the listeners, if you're, worried about responsibility or having to be, I think doctors, our egos, we check them at the door, but we're actually kind of sensitive and worried underneath that we're going to make a mistake and hurt somebody. And that the way that I try to teach people to approach ultrasound is like, try to have a full, safe way to take excellent care of the patient, but also like, you can say that you are concerned about something and it's okay if you're wrong. But use your excellent clinical judgment that was probably built a lot around not using ultrasound, especially for like older physicians who are awesome doctors. And you will be able to kind of make your way to making a case for why you're worried about what you're worried about and like that you have ultrasound evidence to support it. You don't need to know exactly what it's called or exactly what to do even. You just know it's not normal. And that this needs to be addressed. And nobody faults you for that. That's just taking care of the patient.
That's right. That's what we're trying to do. Russ, you have last minute, just words to the wise. Thank you both. Thank you both for hopping on. This has been really fun.
Well, this has been fun. I think the case is great. And it really illustrates the idea that you don't have to know like the funky, crazy anatomy thing. It's just that something's wrong. And that really illustrates for me that the area of specialty is the specialty part, right? And particularly for emergency medicine or general care, knowing that there's a problem is extraordinarily useful. My summary for ultrasound is that as sort of adults, we learn information. We don't usually learn new hand, eye, or skills. The last things that people learn as an adult would be something like a musical instrument or skiing or driving. And we are never going to let anybody drive a race car the first time. Like my 16-year-old is not driving a race car the first time she's learning to drive, right? So we have to recognize that people are learning, but learning new skills are hard. So give yourself a little bit of grace, cut yourself a break, and recognize that you're going to need some practice. And practicing with some good guidelines and some good, helpful people to help you along the way is really going to make the difference. Is it going to change the course of how you practice your medicine entirely? No. Can you incorporate that to help you feel more comfortable making some of your decisions and then also making families feel more comfortable and involve people in your care? Yes.
Two sides of the same coin, buddy.
So fun chatting with you all.
Well, thank you. So that was great. Thank you so much. And thank you everyone for listening and see you next month. Please send in any requests for topics you want to have discussed and look forward to seeing you again. Thank you all.
Bye all.
Bye.